All right, thank you. Can everyone hear me? Just give me a wave if you can hear me. Okay, great.
Good so far.
Okay. Okay, so let's see. What I'd like to do is really talk about treatment in schools for respiratory conditions that you're going to see potentially. Okay, awesome. So again, my name is BenTippets. I'm a pediatric pulmonologist here at St. Luke's. I recognize a few of you through working with you through the schools and through the hospital also. I work at St. Luke's Children's Hospital, and I've been here for about, I can't believe it's been almost 15 years. So we've had lots of kids that we've seen that are in schools and we've interacted some. Let's see. Now, oh, there we go. Okay, so I have no other relevant financial obligations to disclose to anyone today other than I work at St. Luke's, but I'm not involved in any industry or research. So I would really like to make this right about an hour long. So we'll see if we can do that. There are several things that so let me go back for a second. My wife was a former substitute school nurse. And so I asked her, having had some experience with the schools, about what would be most beneficial to talk about with this lecture. So these are a few things that we came up with that she has seen, and then I've had interaction with the schools. And so hopefully I can talk about a few of these and answer a few of your questions. But there's really 5 things that I think are probably most pertinent for kids in school that I'd like to talk about today. So the first one is just chronic respiratory diseases and include tracheostomy. I know that this has been kind of a source of anxiety for taking care of children with tracheostomies in school. And so hopefully we can go through a few of those things. The second one is asthma. And I know that we see lots and lots of asthma at school. And really, I want to focus on both of those primarily. And then if we can get to it, I'd like to talk about cough and both acute cough and chronic cough and what you see at school, some shortness of breath, and then hypoxia also. So again, if there's any questions, please feel free to ask, and I'll make sure that we have time at the end of this to talk about some questions and some cases. So the first thing I'd like to talk about is just asthma. And I think it is helpful to understand the underlying pathophysiology of asthma. So when we think about asthma, we think about your airways, of course, and it's not the really big airway like your trachea, and it's not the very, very small airways that are closer to the alveoli. It's kind of that in-between sized airway problem. And there's really 3 parts to it that I think about that we can direct our therapy at. So the first one is just the inner lining of the mucosa. So on the lower left-hand side, it's the normal airway. And you can see that normal airway is, I'd like to think it's open and you can breathe through that. And there's not a lot of mucus there and there's not a lot of swelling within the airway. So the first thing we think about with asthma is that you have swelling within the airway. And that swelling is there every day or night, sick or well. It's always there to a varying degree. And what we know is that when you have very small airways and they're a little bit swollen, it causes problems. And that's the underlying problem with asthma is just the airway edema. The second thing we think about is just excess mucus. When I talk to patients about mucus, this is what I tell them. I tell them that as an adult-sized person, we all make about a soda can volume of mucus every day. It's about 12 ounces or 240 milliliters. And we cough it out and we swallow it and it's fine. But we know that individuals with asthma just make more mucus than that. And that's part of the reason why they have a lot of cough is because of the excess mucus production. The third thing, or the third part of asthma, is the smooth muscle that surrounds the airways. And those muscles aren't like your arm muscle because you can't consciously control them. So they have a bit of a mind of their own. And they are triggered by certain things. And I have found that everyone is just a little bit different in what they are triggered by. But most commonly, we see that viral respiratory infections by far are the most common trigger for an asthma exacerbation. But we also see dust, we see exercise, we see allergies, we see air pollution. There's a whole host of things. There's some kids have strong emotional responses and their asthma gets worse. I have a little guy that his sisters think it's funny, but they tickle him and they chase him around the house, and laughing makes his asthma worse. So they've had to figure out what to do with that. But there's a whole host of things that can cause an asthma exacerbation. And so figuring out for that child what their exacerbating factors are can go a very long way in trying to prevent them if we can. But we also know that at baseline, you have a certain amount of airway edema, and these smooth muscles are supposed to be relaxed. But when you have an asthma exacerbation, what happens is all three of the things get worse. So you have those smooth muscles that they contract or they constrict, and they're around the outside of the airway, so they clamp down, and that reduces the size of the airway that you're trying to breathe through. If it's related to exercise, often if you can address that smooth muscle, things get better. If it's with a viral respiratory tract infection, you get more significant airway edema, and that's where we need to be more aggressive with our treatment. So this is the underlying pathophysiology of asthma. So as we think about asthma and how do we treat asthma, there are really two main ways that we do it. And I know that all have seen these medications. So the first thing that we think about is a controller medication, and that is typically an inhaled corticosteroid, whether it's budesonide or fluticasone or mometasone. These are the ways that we control your asthma. And we call them controller medications because we want you to take them every day. Now, as we think about controller medications, those medications primarily are taken every day, and they have to be taken every day. And I tell kids that they have to be A students when it comes to taking their controller medication. Typically, these medications are given twice a day, and that's the way that they were studied, and that's the way that I found it works the best, is to take it twice a day. So out of 14 times in a week, I tell them they can miss one treatment, and that's it. But other than that, they have to be really good about taking it every day. Now, there is some evidence that you can give these medications just a little bit differently in specific situations. It's called the SMART protocol, S-M-A-R-T, and it has to do with budesonide formoterol, or Symbicort is the brand name of it. And you'll see us do this periodically, where we'll give the controller medication just when you're sick. I'm not totally convinced that it works great that way, but for a certain subset of patients, it seems to work, that they don't need a medication every day, but they can take their controller medication just when they're sick. The second medication is the rescue medication, and we've all seen this, the albuterol. And these medications really target the smooth muscle, and it causes smooth muscle relaxation. And that's why it works so well, is it relaxes those muscles. Now, as we think about albuterol, we know that you give it works within 10 minutes or so, and then it wears out of your system within about 4 hours. And so I tell patients, I think of it like I think about Tylenol. You give it, but you're probably going to have to give it again 4 hours later. So these are the two main medications that we give. Now, there are some other medications that you may see on the list. One is called montelukast, or Singular. And what I've found, and what the literature would support, is Singular by itself is not a good controller medication. It's really tempting to give because you only have to give it once a day, and it's easy because they just have to swallow a pill. But I have not found that it's good monotherapy for asthma. If you're going to use monotherapy, it has to be an inhaled corticosteroid. Now, as we think about the severity of your asthma, so when they come to see me, what I'm trying to do is I'm trying to figure out how severe is your asthma and how aggressive do we need to be at controlling it. And if you're on a medication, how well controlled are you? So what I try to do is I try to talk about with the family and the patient about how often do they have symptoms and how severe are their symptoms. And we call it the rule of twos. And it's a pretty good way to judge how severe they are and how well controlled they are. So if they're having symptoms more than twice a week during the day, more than twice a month at night, or having two major exacerbations in a 6-month period, that tells me that they're not well controlled and that we need to be more aggressive. So as I have tried to take care of kids with asthma, I have found that this asthma action plan works really quite well if they will follow it. And so every child who comes in, sorry, I'm going to say yes, I'm speaking English. So every child who comes in, I want to complete an asthma action plan for them. And I want to fill it out, and I want to review it with the family, and I want to make sure that they understand it. And then I want them to make a copy of it and take it to you as the school provider to make sure that you have access to it and you know what that child is supposed to do. And so just know that I am reiterating that point, that they need to take it to school and they need to have an updated copy, and you need to know as the school provider what they are taking and when to give the medication and how much. So just as a quick review about asthma action plans, it's divided into 3 zones, a green zone, a yellow zone, and a red zone. So the green zone is what we want them to do when they are well. These are your daily preventative medications, and these in this zone, this is when the child is doing well. They're breathing fine, they're not coughing, they're wheezing, they can run out and play in recess, and they're doing okay. And I'm going to complete this green zone and tell them what controller medication they need to be taking every day, how much, like 2 puffs, and then how often. And it's usually twice a day. When we get to the yellow zone, I tell them that this is when you're sick, when the first signs of a respiratory tract infection, if you've been exposed to a known trigger, if you're coughing, you're wheezing, and you're not really sick, but you're kind of sick. And typically what I do in the yellow zone of the asthma plan is I want them to continue to take their daily medication. Now, I don't expect you as the school nurse to be giving them their daily medication. Very rare exceptions. And that rare exception is when we're not confident that the parents can give them their medication at home. But the problem with giving it at school is they're only there for 4 to 5 days a week, and the child needs to be taking it 7 days a week. So the parents need to have the medication, and taking the medication from school to home and back again every day is a real challenge. And I'd rather them not do that, because I don't think that they're going to be compliant with taking the medication. So in the yellow zone, I want them to continue to take their daily medication, whatever that is. And then typically I just want them to be more aggressive with their albuterol. And I tell families that taking albuterol every 4 hours is very safe to do. And you can give 4 puffs of albuterol, and I'll talk about the dosing in just a minute. Now, if you're giving albuterol and you're not getting better, or you are getting significantly worse, this is when we go to the red zone. And this is where either the parent's intuition or your intuition as a school nurse comes into play. That the medicine is not helping, you've given albuterol already, and they're showing signs of respiratory distress. And that is tachypnea, they're breathing hard, they're wheezing, and actually they may have been wheezing and now they're not wheezing because they're not moving much air. They're showing signs of respiratory distress, they're having retractions, they can only speak in 1 to 2 word sentences. This is where the child is getting into trouble and they need to be evaluated, either in an emergency room, by the primary care provider, by us, but they need to be evaluated and they need to be seen relatively soon. Now, like I said, I would like every child with asthma that's not mild intermittent. Mild intermittent asthma means that you just need albuterol once in a while, but anything that's persistent, the definition of persistent is you need to take a medication every day. So every child who has an everyday medication that they take, I want them to have an asthma action plan, and I want them to have a copy of their asthma action plan with you at the school so you know what to give them. Now, feel free to contact our office if the child is on a daily controller medication, has an asthma action plan, but they haven't provided one for you. And I will get one for you to get it to the school so you have it. And really, I want them to have that there because I want the child to be successful and I want you to be successful also at the school. Now, a few other points here. So as we go back, you'll see that typically in the asthma action plan, it'll talk about a peak flow reading. Now, I have to admit that peak flow meters are not a routine part of my practice. And I think it's partly because the people that taught me asthma did not like peak flow meters. And I understand why they didn't like peak flow meters, but peak flow meters can be helpful in the right situation. And we have one in my clinic and I dust it off periodically and I put it back on the shelf. And I'll explain it to people that want to know about it, but I don't routinely have the kids have a peak flow meter. Now, but if they do have a peak flow meter, we need to know how to define what is in the green zone, what's in the yellow zone, and what's in the red zone. So with a peak flow meter, what you need to do is use proper technique. Um, and you need to do it repeatedly or try it repeatedly, because what you're looking for is you're trying to figure out how much air you can get out of your lungs. And that's, you take an average over time of what your very best is, and that's what you set as your green zone, between 80 and 100%. And so if you're at school, you're using a peak flow meter, and if they're between the 80 and 100%, they're in the green zone. If you're concerned that they're not doing well and they're between the 50 and 80th percentile, then they're in the yellow zone, and below the 50th percentile is the red zone. Now, the part of the reason why I don't really like to use peak flow meters is I'm just not confident kids will always give us their best effort, or they know how to manipulate it. I found that if you roll your tongue inside the peak flow meter, the mouthpiece, you can increase the velocity of air, which falsely elevates the number that you get. And so if the child really doesn't want to go to the school nurse, go to the emergency room, they can manipulate it. Also, they have to give you a really good effort, or they'll give you a falsely low number. So for those children who have peak flow meters, can use them reliably, and it's helpful, I'm more than happy to use it, but I'm always skeptical about peak flow meters, to be honest. Before I go on, Jocelyn, are there any questions in the chat that I need to answer?
Not yet. Not so
okay, perfect. Okay, so let's talk about nebulizers versus inhalers. There is a discussion out there about which one is better, which one is worse, which one you should use at school, which one you should not use at school. And in the end, I would say that whatever way the child will use the medication and works the best, that's what I want them to use. Now, I do like metered dose inhalers. The reason I like metered dose inhalers is they're a little more portable, they're individualized to the patient, and they're relatively easy to use, and they're effective if you use them correctly. I recognize that for some children, nebulizers work better. The problem with a nebulizer in the school environment is, does the child need to have their own nebulizer and their own tubing and their own face mask and their own medication, which is much more bulky, and you have to transport it back and forth from home. And so the vast majority of children that I take care of in my practice, I want them to use a metered dose inhaler, and I would really want them to have a metered dose inhaler at school. And so let me know if you're having a hard time getting a metered dose inhaler for school. Now, the one challenge with a metered dose inhaler, and really all of the asthma medication, is the vast majority of insurances will only pay for one inhaler per month. So one inhaler of a controller medication like budesonide, formoterol, or fluticasone, there's 120 doses in each one. So if you take 2 puffs twice a day, that's 30 days. And so it lasts you exactly 1 month. So you have to fill it every month. With an albuterol inhaler, there's 200 actuations in it. And for children that don't need it every day, they don't necessarily need to fill it every month. So what I tell, but you can still go pick it up from the pharmacy every month. So what I tell families to do is go pick up one, at the end of the month, pick up another one, and then pick up another one. So they can stockpile a few of them, so they can have one at home, they can take one to you at school, and they can have one in their vehicle or somewhere else where they might need it. And so I'm constantly advising and suggesting to families to make sure that they have the appropriate medication at school. And if you have a hard time with families getting the appropriate medication, just let me know. But in the end, I actually don't care, nebulizer versus inhaler, what they use. I just want it to work in the end, and if they can use it appropriately. Okay, so with a metered dose inhaler, every child needs to use a valve holding chamber. I tell children, because they always ask me, are they old enough to use it? Or am I too old to use it? And I tell children that when you're born, you're old enough to use a valve holding chamber. And when you die, you can stop using your valve holding chamber. But between those two times, that you need to use a valve holding chamber. Now, the reason is this. If you use an inhaler and you stick it right at the edge of your mouth and you depress it and inhale right at the same time, you take a big breath, you get the science would say that you get about 10% of the medication in your lungs where it's supposed to go. And as the plume of medication comes out of the metered dose inhaler, the other 90% coats the inside of your mouth and the back of your throat, and you swallow it. And that doesn't help. If you use a valve holding chamber and use the correct technique, the science would say that you get about 20 to 30% of the medication in your lungs where it's going to be helpful. So you get 2 to 3 times the dose if you use a valve holding chamber versus if you don't. And you obviously need to use the appropriate technique. There is only one exception to that rule, and it's for children who have a disease process called eosinophilic esophagitis. And what they want you to do is swallow the medication. So it's an inhaled steroid, and they do not want you to use an meter dose inhaler. But that's a stomach problem, not a lung problem. So for all lung problems with meter dose inhalers, you have to use a valve holding chamber. Now, I tell families that about every 6 to 12 months, if they're using it on a regular basis, it should be replaced because it doesn't last forever, and it should be washed periodically. About once a month or so, they should just rinse it out with soapy water and let it air dry. I do warn the families that they should not put it in the dishwasher. And the reason is, particularly with older dishwashers that have a heating element, it gets too hot inside the dishwasher and it will melt the spacer or the valve holding chamber. And then you have to get a new one. So just tell them to rinse it with soapy water once a month and then rinse it out and let it air dry. And probably at the school, in the school environment, that should be the same, that you should wash it once in a while. So those are valve holding chambers. Now, the question is, how do you use a valve holding chamber appropriately? And really, there's two ways to do it. Use a valve holding chamber. And these, if you ever get a valve holding chamber, particularly the aero chamber, they're colored orange, which is probably too young for a child because those are for neonates, but they'll either be yellow or blue. So for a child that can cooperate with it and they're old enough to understand how to use it, what you do is the first thing you need to do is place the inhaler in the appropriate location on the valve holding chamber. You need to shake up the inhaler to mix the medication a little bit, and then you can put your mouth around the mouthpiece, depress the inhaler for one puff to come out, and then you can take a deep, slow breath and hold it for 6 seconds. I tell the children, if the spacer is making a musical noise, you're breathing in too fast. But you just want to take a deep, slow breath and hold it for 6 seconds, and then you can breathe out. Now, what we don't want you to do is put 4 puffs inside an inhaler and then take a deep breath for 6 seconds and hold it. You need to use just 1 puff at a time of the inhaler. Now, for children who can't coordinate that deep breath and hold it for 6 seconds, what you can do is put 1 puff inside the inhaler, and then they can take, it says here, on 2 to 3 breaths, 2 to 3 regular breaths. And what you're trying to do is just evacuate all of the medication from the inside of the chamber and be able to breathe it in. But those are the 2 ways to do it. And done appropriately, I really feel that using a valve holding chamber and a meter dose inhaler works really quite well. So are there any questions about that? I don't see any.
Yeah, there don't seem to be questions. I do want to mention that someone asked for the PDF version of the asthma action plan. We did find that, so the link is in the chat if that's something you're interested in.
Okay, excellent, perfect. Now, at school, what do I expect you to do? So if a child has asthma and they have a viral respiratory infection, you have their asthma action plan and you have a meter dose inhaler with a valve holding chamber there, what should you do? I would hope that you would have a stethoscope that you can listen to them. And while you're listening to them, a few things that you should listen for is something called polyphonic expiratory wheezing. Now, polyphonic means that there's a whole bunch of different pitches of noises that you're hearing. So you're hearing some that are low pitched, some that are high pitched, some that are medium pitched. I think about playing 10 piano keys at the same time. They're all different sounds, and that's what you're going to be hearing. If it's the same sound over and over again in the same spot, that may not be asthma. That may be something different. So what we're talking about is polyphonic wheezing. There are lots of different pitches of wheezing in different areas of the lung. We're listening for decreased air movement, and that can be a little bit harder to recognize just because every child's just a little bit different, and unless you're listening to them frequently, you may not be able to make the subtle difference between lots of or normal air movement and decreased air movement. But there's some generally we can say that they have less air movement versus normal. And the third thing that we're looking for is what's called a prolonged expiratory phase. When you breathe in, the time that you breathe in should match the time that you breathe out. And if it takes you a long time to breathe out, that means that there is some obstruction in the lung, like asthma, and you're able to get the air out, you just can't get it out very fast. So as you listen to them, those are the types of things that we're listening for. The second thing what we should do is make sure that there's medication in the canister. There have been several occasions in my clinic where I asked them to look at the back of the canister, the meter dose inhaler, and tell me the number, because most of those have a counter on them that will tell you how much medication is left inside the canister. Now, I recognize that there are a few that don't have a counter on it, and those are a little bit harder, and you have to keep track of how many puffs are still in it, which can be done. It's just a real challenge, but the vast majority of them have a counter on the back. And then finally, just making sure that they use the correct technique. Now, after you give them albuterol, what I would suggest is that you repeat an exam. And I wouldn't do it within a minute after giving the albuterol because it's not going to be really taking full effect by then. But within 5 to 10 minutes after giving albuterol, I would expect it to be working. And so listening to the child again, listening for wheezing, air movement, that prolonged expiratory phase, that's what you're listening for. And then knowing when to give it again. Now, we think that albuterol lasts for about 4 hours. And so I tell patients to not be scared to give it every 4 hours. And I always give them the example, when you're in the hospital, I give you lots and lots and lots of albuterol, and I don't want them to give it more than every 4 hours because we can't monitor them very closely. But in the hospital, we give it, we give the equivalent of 16 puffs every hour. So it's a lot of medication. But for the patient in the school environment, they need to know when to give it again. And if you're going to give it, you should probably tell the parents when you gave it and when they can give it again. Okay, so that's the asthma part of this. And I'm about 30 minutes into it. So I think we're right on time here. There are a few other chronic respiratory diseases that we have with children that attend school. And they all have their own challenges. For children who are tracheostomy dependent, it can be a real challenge, and I'll talk a little bit more about that. But we all know that there are children out there with cerebral palsy, and they have some unique challenges. Dysphagia is a big one, that they really have a hard time managing their secretions and swallowing their secretions appropriately, which just puts them at an increased risk of having respiratory problems and recurrent respiratory infections. That goes along with chronic aspiration also, and it's not unusual for them to have some airway obstruction. And we know that there are some children that have significant tracheomalacia or laryngomalacia that in the right circumstance can get them into trouble. Now, the last chronic respiratory disease that's more common is probably cystic fibrosis. In the Treasure Valley, we have about 75 kids that we see in our cystic fibrosis clinic. About 50 of those live in the Treasure Valley. We do see a few from northern Idaho, eastern Idaho, and then into Nevada also, and Oregon. And the vast majority of those children shouldn't need to do treatments during the school day, but there are going to be some times when they may need some treatments. So, and their treatments are a little more specific. So let's talk about tracheostomy for a minute. As I was talking to my wife, who's the former school nurse, she was talking about kids with tracheostomies and what do you do with them at school. Tracheostomies are challenging, and I totally recognize that. And there's lots of different reasons why children have tracheostomies. Just to name a few, if a child has a significant upper airway obstruction, like subglottic stenosis, or we have a child that has vocal cord paralysis, and we need to bypass her upper airway for her to be able to breathe. We put in a tracheostomy tube for that. There are children who are ventilatory dependent and need a tracheostomy tube for a home ventilator. And some of those children are on the ventilator 24/7, 24 hours a day, and other children just need it when they're sleeping at night. We do take care of a few children who have something called congenital central hypoventilation syndrome, which is they forget to breathe when they're asleep. And so during the day, they don't need to use their tracheostomy tube necessarily, but at night they need it. For children who have recurrent respiratory tract infections and we need to be able to administer medication or oxygen or some other type of medication through the tracheostomy tube, or if they have a real challenge with respiratory infections, and we need the tracheostomy tube for that. And then the last one is for children with particularly cerebral palsy who really have a hard time managing their airway secretions, just to be able to have access to their airways to be able to suction. Those are the main reasons why children have tracheostomy tubes. Now, the challenge with tracheostomy tubes, and I recognize this, and I tell families that for the most part, not every child, but for the most part, that child is dependent upon that tracheostomy tube to breathe. And I tell families that they're really 5 minutes away from permanent neurologic damage and 10 minutes away from death, really at all times. And that's because if their tracheostomy tube becomes dislodged, comes out, or if it gets plugged and they can't breathe, they're at risk of having something bad happen. And so for those children with tracheostomy tubes, they really do need someone available that can intervene on their behalf if they need it really all the time. And so what we do at home is we teach the families how to take care of kids with tracheostomy tubes and how to manage it and how to manage emergencies with a tracheostomy tube. But we also want them to have a home nurse to be able to manage their tracheostomy tube also. Now, I recognize that the school needs to have a nurse to be able to take care of this child also. And that's where it gets to be challenging. And I recognize that because you as a school nurse aren't always willing or ready or able or trained to take care of a child with a tracheostomy tube. And so I've gotten the feeling over the last year or two that we need, you as school nurses and us as medical providers need to come up with a way to make sure that the child can attend school, because I always think it's good for the child to attend school, but also to make sure that they're safe and that you feel comfortable taking care of a child with a tracheostomy tube. Now, just to go a little more detail into what tracheostomy tubes are. So these are two different types of tracheostomy tubes. The tube on the left is a cupped tracheostomy tube because it has a balloon at the end of it, and that blue part is where you can attach a syringe and fill that tube with air. Now, the reason why it's filled with air is because either number one, they're on a ventilator and we need to keep all that pressure inside their lungs, and that tube prevents air from escaping the lung around the tube, or they have a really hard time with managing their airway secretions in that tube. Partially, it doesn't always or completely, but it partially prevents secretions from going past that balloon. Now, the tube on the right is an uncuffed tube, and it just fits inside the airway, and you can get air around it, you can get secretions around it, and that's more for children who just need like a ventilator at night or need to bypass their upper airway to be able to breathe. Now, the two things that I think that are probably most important in the school environment to be able to know how to do is how to suction a tracheostomy tube and how to put a tracheostomy tube back in. Now, as we think about suctioning a tracheostomy tube, there are a couple just general things that we think about. The first one is making sure we do it in a way that it's not introducing an infection. There are several different catheters that we can use to suction. Some of them are like this one on the left side, where it's just the catheter and that's it. If that's the case, we just want to make sure that our hands are clean and that we're not introducing anything on the side of the catheter that would be detrimental to the child. There are others that are within a plastic sleeve that are kept cleaner, and then another one called a Ballard, which is permanently inside a sleeve that you don't have access to touch the catheter itself, and those are more clean. We use those typically more often with children who are on a ventilator also. A couple of thoughts about suctioning. The first one is, if I go back, oh, not that one. If I go back, you can see that the tracheostomy tube is only so long. And what we want to do with a suction catheter is make sure that we don't extend that suction catheter past the end of the tracheostomy tube. And that's mostly because the inner lining of the trachea is very sensitive. And if the catheter is going past the end of the tracheostomy tube and touching that mucosa repeatedly, it can cause some damage to the inner lining of the trachea, and you can get extra growth of tissue. It's called granulation tissue. And built up over time, it can actually obstruct the end of that tracheostomy tube, and that's not good. But it can also cause some bleeding and some damage to the trachea itself. And so we want to make sure that you know how far you can go through the tracheostomy tube, the suction. And we want to go to the end of the tracheostomy tube, but not past the end of the tracheostomy tube. So the second thing is about reinserting the tracheostomy tube. It freaks people out. I'll be honest, it's always nerve-wracking the first time you reinsert a tracheostomy tube, but I think of it kind of like an earring in that it's all technique. And once you feel comfortable doing it, it's actually really quite easy to do. But it is important to be able to know how to reinsert that tracheostomy tube safely and how to do it relatively quickly. The reason is that if that tracheostomy tube comes out and it's out for probably more than 10 minutes, that the stoma or the hole will start to close. And it gets hard to put the tracheostomy tube back in there. So the tracheostomy tube actually holds that hole open, or tracheostomy open. And if it's not put back in, if it comes out relatively quickly, it starts to close. And just on Monday, I had a child that the tracheostomy tube came out. They didn't recognize it for about 30 minutes. And then they couldn't put it back in because the hole had already started to close. Now, we do want, and you probably should have at school, we want the appropriate size tracheostomy tube, but we also want one size smaller. For that occasion where it comes out, it's hard to put it back in, the appropriate sized one. And so you have one size smaller that you can put in an emergency to keep that airway open. And so the question is, how do you get trained to do all of this? And if any of you have any thoughts about that, let me know. My clinic nurses and I and the hospital staff have thought about this on many occasions, and I don't know that I have a great answer, but I'm open for suggestions. Now, the other thing about a tracheostomy tube is making sure that it's not going to come out. All tracheostomy tubes have these little ties that go around the neck. It's usually a felt band that has a Velcro on it that's adjustable. And when you put a tracheostomy tube back in, it needs to be secured in place, but not too tight. Because if it's too loose, then the tracheostomy tube can come out by itself. If it's too tight, it cuts off circulation to that area of the skin. It can cause some problems, particularly to the stoma or the tracheostomy itself. So we typically say when you put a tracheostomy tube and secure it, you should be able to put one or two fingers underneath the tracheostomy tie. And if it's that tight or that loose, then it's appropriate, and the tracheostomy tube should not come out.
There is one question that just came in.
Okay.
Is that 10-minute reference for newer trachs? So a student who has had a tracheostomy, okay, I get it, for several years, there's not the 10-minute urgency.
You know, it's interesting. I would like to say that if you've had a tracheostomy tube for a few years, that could come out and it wouldn't close, but that's not true. The patient that I had on Monday has had a tracheostomy tube for a year and a half, and it started to close within just a few minutes. And so even those patients who have had it for several years, I'm concerned that it's going to start to close. So I would say, just as a general rule, that if it comes out, it's going to start to close within 10 minutes or so. And I can't say for adults, if you've had a tracheostomy tube for decades, because I'm a pediatrician and I don't see them past 18 years old, that it may get to the point that it's more stable. But for children, I think that's pretty typical that it will start to close within a short period of time.
Thank you.
You're welcome. I hope that answers that question. Okay, so the other question is, if it's not attached to a ventilator, what else can you put over a tracheostomy tube? So there's two things that I want to talk about here. The first one is what's called a speaking valve. And we do have a number of children who attend school who wear a speaking valve during the day. Now, the other names for a speaking valve, there's one called a Shiley speaking valve, and then what's called a Passy-Muir valve. And I think it's after a guy whose last name was Muir. But what this is, it's a valve, it's a one-way valve that you can breathe in through the tracheostomy tube, but when you breathe out, that valve closes and the air has to go around the tracheostomy tube and come out your mouth and nose. The advantage of this is that you can speak because you need air going by your vocal cords to have a voice. And so for those individuals who don't need a ventilator or don't have a significant upper airway obstruction, we typically want to use a speaking valve like this, and so they can have a voice. I think it also aids a little bit with humidification if you can breathe through your upper airway, because that's where we all get our humidification for our airway. Typically, patients can tolerate this all day if they can tolerate it. And that's ultimately my goal if they're able to wear it, particularly wearing it at school is what we would want. And it just fits right over the end of the tracheostomy tube, but it can come off for suctioning, or if there's an emergency that it can come off. So the second thing is what's called a heat moisture exchange. We also, the slang term is an artificial nose. Now we know that our nose and sinus and upper airway are the perfect humidification device for ourselves. And by the time, even in dry areas like Idaho, by the time the air gets to the back of your throat and into your lungs, it's 100% humidified. Now, if you have a tracheostomy tube, you're bypassing your upper airway and you don't get any more humidity than what's in the air. And during the summer when it's hot and it's dry, we have very low humidity, and that's not good for all the mucus that's in your lungs. And the problem is that if you're breathing just regular unhumidified air, that your airway secretions become dehydrated, and then it becomes thicker, and you can have mucus plugs that can occlude the airway. And I have had children who have had a large mucus plug and did not survive it. And so we are pretty neurotic about making sure that you have humidification. Now, this heat moisture exchange or artificial nose is pretty good at it. And it fits right over the end of the tracheostomy tube, and there's some filter paper in it. And what it does is you breathe out, it captures the moisture that you're breathing out. And then as you breathe back in, it rehumidifies the air. Now, these HMEs are not meant to be used all day. At some point, that filter paper becomes saturated and really stops working. And so I ask patients to not use it all day, the same one all day. You can change them, and that's fine, but you should not use one for the entire day. Now, the other thing that we can use is a humidifier, or what we call a mist mask. It creates humidity, and it's almost like a nebulizer mask that fits over your tracheostomy tube, and it provides humidification for you. For children who are on a ventilator, there is a humidifier that goes along with the ventilator that will humidify the air. But really, the whole reason for this is humidification and making sure that your airway secretions are not becoming dehydrated, because it can be a really big issue. Okay, so there are a couple other pieces of equipment that might come with children who have chronic lung diseases. And so, sorry, let me go back. I hope I've been able to answer all your questions about tracheostomy tubes, and I hope to leave a few minutes at the end, which we're getting close to.
About 6 minutes, just so you know.
Okay, I'll be quick. So this is a cough assist machine for individuals who have a hard time clearing their airway, either to a weak or ineffective cough. A cough assist machine can be very helpful. These are primarily used for individuals who have neuromuscular disease like Duchenne's muscular dystrophy or spinal muscular atrophy, and that just have a very weak sounding cough. And what it does is it blows air into you and then it sucks that air back out. So it reproduces a cough for you. This is what we call airway clearance. This is a pneumatic vest. These primarily are used for kids with cystic fibrosis who have a hard time getting mucus out of their lungs because it's so thick and sticky. But we will frequently use these for children with impaired airway clearance, such as cerebral palsy, or individuals who just have a hard time getting all that mucus out. But these can be very effective. I would not expect you to use this at school. This is something that should be used at home. And if they're sick enough that they need to use it at school, arguably too sick to be at school. So I hope that you don't have to use this very often. Okay, so briefly, cough. And I'm going to go through this really pretty quick. You guys see lots and lots of cough. This is the basics of cough and how it all works. I love this picture because this is what we worry about is people coughing on each other, particularly right now that there's lots of RSV in the community. And this is how respiratory diseases are passed. So acute cough, it's defined as less than 3 weeks in duration. Most oftentimes it's a viral cough, but we have seen, and I know that you've seen this, is pertussis in the community this last year. Pertussis has been really challenging, and it goes from acute cough to being more of a chronic cough. But by definition, they're self-limited. I love this picture, and if there's any slide to go back to, this is probably the one I want you to go back to. This is the timeline of a viral respiratory infection, and the purple line is a cough. And with a viral respiratory infection, you get fever, sore throat, and nasal discharge, and as all those symptoms go away, this cough can just linger, and it can linger on for a very long time and can be very challenging. But that is a normal timeline for an acute viral respiratory infection. So what do you do about it? Sometimes it's reassurance. Sometimes it's call the parents if we feel that they're sick. Sometimes it's albuterol. Over-the-counter medications, we don't use a lot of those. The one medication I will use is guaifenesin. And guaifenesin, what it does is that it's Mucinex, and it makes your secretions thinner so you can cough them out easier. For chronic cough, how long is too long? I typically say more than 8 weeks, somewhere between 4 to 8 weeks. I understand that chronic cough is a serious issue with kids who have chronic cough. It significantly impacts the school, attendance, sleep. It's hard to have a child cough in your classroom all day. And so I recognize that it's really challenging. Common causes of chronic cough, protracted bacterial bronchitis is a big one that I see. This is kids that have a smoker's cough that lasts for a really long time, and it's just a smoldering infection is what it is. This is the algorithm that we go through for kids with chronic cough and all the different things that can cause it. Okay, the last one I want to talk about really briefly is just hypoxia. When I think about hypoxia, there's really only 5 reasons why you have low oxygen saturation levels. And the first one is that you're at a top of a tall mountain, which we're usually not. So we can exclude that one pretty easy. But the biggest one that we see is something called a VQ mismatch. And V is blood and Q is air. And if there's a mismatch of blood and air within the lung, that's what causes low oxygen saturation levels. So like pneumonia, like asthma, or a blood clot, if there's a mismatch between the two. And I would encourage you to be somewhat skeptical about pulse oximeters and the accuracy of pulse oximeters. I call them akin to the devil because they're always notoriously inaccurate, and they're typically low, inaccurately low versus they're always inaccurately low. They're never falsely high. So they're always low. So always be skeptical of the number. And I always ask people to focus more on the clinical symptoms than the number itself. Okay, so I have just a couple minutes. And if anyone has any questions, I would be more than happy to answer them.